Welcome to Closing the Gaps, evidence on promoting safe and effective patient medication adherence in chronic disease. My name is Kathy Russell-Babin, and I will be the moderator today. The Institute for Evidence-Based Care is pleased to offer today's webinar. Continuing education credits are available for nursing and medicine. APCE credits for pharmacists are pending. Please email our speaker, Lisa Antonacci, for further information regarding them. Participants must remain for the entire session in order to claim continuing education credits. Participants must complete the appropriate session evaluation form, found either in the group session or on the website. If you are attending this outside the group session, please fax it to 732-776-4837 with contact information for your returning certificate unless you're in that group session. We need to be able to return the certificate to you. A few housekeeping announcements. One nursing contact hour will be provided by the Meridian Ann May Center for Nursing, which is an approved provider of continuing education for nursing by the New Jersey State Nurses Association. Accreditation status does not imply endorsement by the Ann May Center for Nursing or ANCC of any commercial products or services. Meridian Health is also accredited by the Medical Society of New Jersey to provide continuing medical education for physicians. Meridian Health designates this live activity for a maximum of 1 AMA PRA Category 1 credit. There is no commercial support for this activity, and the speakers have declared that they have nothing to disclose. The program is free of bias. A few additional housekeeping details. This webinar is being recorded and will be available for viewing for at least the next 6 months for Meridian employees via the webcast website, www.meridianiebc.com. It will be available online 24/7 throughout this time. It plays in both YouTube and media play formats. Availability will begin approximately 2 weeks after this live broadcast. Please encourage your colleagues to complete the webinar. We will not have time for questions today, but welcome any that you may have for our expert. Please send any questions to Kathy Russell-Babin at the email address on the screen, and we will ensure that you receive a prompt response. A bit about our speaker today, Lisa Antonacci, Pharm.D. Lisa received her Bachelor of Science in Pharmacy from Rutgers University College of Pharmacy in New Brunswick, New Jersey. She received her Doctor of Pharmacy from the University of Sciences in Philadelphia, PA. Lisa has over 20 years of management and clinical experience with an emphasis on the development and implementation of innovative clinical programs and the provision of education and training to various healthcare professionals. Currently, Lisa is the pharmacy manager at Ocean Medical Center. However, Lisa has been at the forefront of pilots throughout her career to improve medication safety and adherence while increasing also satisfaction for patients. The objectives of this program are to describe medication non-adherence prevalence and associated patient consequences, to identify common predictors of medication non-adherence, to review the comparative effectiveness of interventions in improving medication adherence, and to identify innovative strategies to improve medication adherence and reduce hospital readmissions. We are very pleased to have Lisa as our speaker today, and I turn the program over to her at this time.
Thank you very much, Kathy. Patient adherence to medications is a very complex topic. So to get started, I think this quote from 1985, while it's almost 30 years old, is still very relevant. When C. Everett Koop was Surgeon General of the U.S. serving under Ronald Reagan, he was quoted as saying, "Drugs don't work in patients who don't take them." This still definitely holds true 30 years later. What we now know is poor medication adherence is a leading driver of hospital admissions and readmissions and the cause of approximately 125,000 deaths annually in the United States. To put that into perspective, that's twice the number of people killed in auto accidents each year. Non-adherence accounts for 10 to 25% of hospital and up to 40% of nursing home admissions. When we look at all medication-related hospital admissions in the U.S., up to almost 70% are due to poor medication adherence. I think we can all agree that medication adherence is certainly a problem in the U.S. and actually throughout the world, but I want to take a few minutes to actually quantify the problem. More than half of all Americans live with at least one chronic condition, and this percentage is anticipated to rise substantially in coming years as our population is aging and health risks such as obesity continue to rise. We have 32 million Americans taking 3 or more medications daily, and 75% of them are expected to be non-adherent at any given time. Also, more than half of all Americans with chronic illness don't follow their physician's medication and lifestyle guidance. Some background stats, and this is from the American Heart Association for cardiac patients. For every 100 prescriptions written, 88 of them are filled, only 76% of them are taken, and 47% are continued for the appropriate duration of therapy. This next slide lets us look a little bit further. The source is from the National Association of Chain Drugstores, and the data is across all the spectrum of diagnoses and therapeutic drug classes, and I found this information to be very interesting. For every 100 prescriptions written, 50 to 70 actually get to a pharmacy. Only 48 to 66 of them come out of the pharmacy as filled prescriptions. 25 to 30 are taken properly, and only 15 to 20 are refilled as prescribed. This next slide is from a study from 1993 looking at hypertensive patients and adherence to medications and total annual healthcare costs. So if you look toward the left of the bar graph, you'll see the 100% compliant patient. That's the patient that takes nearly all of their medications. And you see the healthcare annual cost are about $4,800 for that type of patient. Next, you see the patient who purchased some but took all of what they purchased. That patient's total annual cost is about $6,400. The next one, though, is more than double the cost of the adherent patient. This is the non-adherent patient. This is the patient that purchased only some of what was prescribed and does not take it regularly. What's interesting to note is that this data represents only one patient and the burden on the healthcare system for that one patient. This next study is from Sokol et al. From 2005, and this study looked at total cost for 1 year for patients with diabetes. This included drug cost and total medical cost. If you look at the less than 20% adherence level, that patient cost $9,000 for 1 year to treat. That's including medications. If you look at your patient near 100% adherence, the 80 to 100 marker, you see the patient is costing the system $5,000 a year. So not only are admissions and readmissions an issue with suboptimal adherence, length of stay is also a problem. When we look at healthcare dollars due to non-adherence, we're talking about $290 billion per year, and the rate of non-adherence is expected to increase as the burden of chronic illness also increases. I want to take a minute to go over some of the terms that we're going to be using throughout the presentation. We interchangeably use the terms compliance and adherence when we're talking about a patient taking their medication, but in 2003, the World Health Organization made the term adherence the preferred term, and they define it as the extent to which a person takes medications as prescribed by their healthcare providers. Persistence is defined as the ability of a person to continue taking medications for the intended course of therapy. Persistence can refer to a short course of therapy, 7 to 14 days, or even a long-term chronic lifetime therapy. So when we look at persistence rates, even those with newly diagnosed, they truly do decrease over time. We look at a study from 1999, and this is in newly diagnosed high blood pressure patients. They're reported to be about 78% adherent after 12 months and only 46% adherent after 54 months. Another source from 2005 shows us that only 50% of patients with chronic illnesses maintain good adherence over time, and they define good adherence as taking greater than 80% of medication doses. So the study that we spoke about a few minutes ago from Sokol et al. Found that for a number of chronic illnesses, diabetes, hypertension, hypercholesterolemia, and congestive heart failure, higher rates of med adherence was associated with lower rates of hospitalization and a reduction in total medical costs. So although drug costs are a relatively small fraction of total healthcare costs for these conditions, they truly have high leverage. So a small increase in drug costs, which is associated with improved adherence, can produce a much larger reduction in medical cost, and this really is key. So a little bit more from Sokol et al. This really was a landmark trial that looked at these 4 illnesses. The results of this study, when you look at these 4 illnesses, heart failure, diabetes, hypertension, and hypercholesterolemia, when you look at the low end of adherence, let's take heart failure to start, the 1 to 19% range of adherence, you see the hospital risk is 85 versus a patient who's at the higher end of taking their medications between 80 and 100% adherence, their hospital risk is about 75. When you look at diabetes, hypertension, and hypercholesterolemia, the results are even more significant. Diabetes goes from a 55 risk to a 28, hypertension from 55 to 25, and hypercholesterolemia from 25 to 15. These are significant changes. So numerous studies associate better outcomes with good medication adherence. I've listed some of them for you here. Just to highlight a study from 2009, they correlated non-adherence in patients with hypertension with a 5.4 times increased risk of hospitalization, rehospitalization, or premature death. So just a quick recap and a quick summary of the prevalence and consequences of poor med adherence. It's a leading driver of hospital and nursing home admissions and readmissions. We've seen several studies that found overall healthcare costs are much higher for patients with poor adherence, especially in those with chronic illnesses. So we're going to shift gears a little bit. I think it's important to recognize and understand why a patient may be non-adherent to their medication regimen. In 2003, the World Health Organization identified 5 dimensions or classes of factors for adherence: social and economic related factors, health system, healthcare team related, therapy, condition, and patient related factors. We're going to go through each one of these with some examples of each. So to start off, social and economic, race and socioeconomic status can certainly play a role. The next 3, cost of medications and copay, lack of health insurance, and unstable living conditions. Certainly if a patient can't afford to pay for their medications or even pay for some of the hefty copays that we're starting to see, their chances of non-adherence certainly do increase. Then we have some patient-related factors, gender and age. While many believe advanced age alone is associated with increased medication non-adherence, most studies actually demonstrate that it's not as important a factor as we would think. Advanced age alone is correlated with improved adherence rates. But some of the other factors that could negatively influence adherence are forgetfulness, treatment anxiety, maybe misunderstanding the instructions, visual, hearing, or cognitive impairment, impaired mobility or dexterity, and swallowing problems. The next group of factors relate to the healthcare system itself and the provider. So there could be a lack of knowledge. There could be an issue with the patient-provider relationship, and we'll continue to talk about this theme as we go through the presentation. This is so important. A recent meta-analysis of physician communication and patient adherence to treatment found that there's a 20% higher risk of non-adherence among patients whose physician communicates poorly than among patients who felt that their physician communicated well. This really is a common theme. And then, of course, there's a lack of knowledge on adherence and of effective interventions for improving it as part of the healthcare system, and a disparity between the health beliefs of the health provider and those of the patient. These beliefs really need to be in sync in order for effective treatment to take place. Next, we have therapy-related factors. Duration of treatment. Treatments that require mastery of certain techniques. What comes to mind is a respiratory inhaler. Patients really do need to know a certain technique and how to use the device properly. Side effects. These could be actual side effects, perceived side effects, or even side effects that a patient may fear may happen. Frequent changes in therapy certainly can be confusing to a patient. Lack of immediate benefit. Treatment interfering with lifestyle or requiring significant behavioral changes. And then finally, complexity of the regimen. And we're gonna focus in on this a little bit. And what I'm referring to are the number of daily doses or the number of concurrent medications that a patient is taking on a daily basis. This slide by Claxton et al. In 2001 takes a look at the correlation between dosing frequency, how many times a patient is taking a medication per day, and adherence rates. And what it shows, we would pretty much intuitively expect. 1 time per day dosing is about 80%. When you go to 2 times a day, it drops to about 70%, 69%. 3 times is 65%. And 4 times a day is only 51%. So you can certainly see the correlation between dosing frequency and medication adherence. Condition-related factors. This is the final grouping. Comorbidities and symptom severity and level of disability certainly are factors to consider, but the 2 major factors on this list are drug and alcohol abuse and depression and psychiatric disorders. There are several studies that look at psychiatric illness as one of the major predictors of non-adherence. This next slide is a little bit of a different way of looking at the factors that affect medication adherence and how they're very much linked and intertwined with each other. So let's take a complex medication regimen. Adherence can be affected by motivation, it can be affected by communication barriers, substance abuse, mental illness, so they really are very intertwined and almost can't be separated. Okay, let's move on to our next objective and review the source of some of the studies that looked at interventions to improve medication adherence. We're going to start off reviewing interventions in heart failure patients. So we've seen improvements in outcomes over the past 10 to 15 years, and we think that they're partially explained by increases in prescribing rates of medications such as ACE inhibitors, beta blockers, and diuretics. Higher levels of med adherence among Medicare patients with CHF were associated with lower cumulative Medicare spending over 3 years, and these savings generally exceeded the cost of the drugs in question. This data is from 2012, very recent data. Another study looked at full adherence and defines it as filling enough prescriptions to have daily medication available for 1 year. It found that it may be as low as 10% in heart failure patients. So when we looked at a systematic review that was published in Circulation in 2012, in order for a child to be included, there were certain inclusion criteria that we're going to take a quick look at. The study had to be a randomized controlled trial in which an intervention group was compared with treatment as usual or a clearly justified comparative group. The patient needed to be an adult with a diagnosis of heart failure, and the intervention strategy clearly had to have a primary or secondary aim to increase adherence to medications. Self-administration was measured as an outcome by any of the following methods: pill count, e-monitoring, refill or prescription records, and self-reported data. So already I think we can see the measuring of self-administration is clearly a challenge. So when we look at the results as we move forward, please keep in mind that there's no standardized way to measure compliance. So again, the study inclusion criteria, the review started with a little over 1,600 relevant papers, and after inclusion and exclusion criteria was considered, it's been trimmed down to about 16 studies that meet the established criteria. What we're going to do is take a look at those studies and the interventions, and we've broken them down into 4 different categories of interventions studied in heart failure patients. The first one is patient education and information. There was a study that was done. It was a prospective randomized trial of the effect of a nurse-directed multidisciplinary intervention on rates of readmission within 90 days of hospital discharge, quality of life, and costs of care for high-risk patients. And these were 70 years of age or older who were hospitalized with heart failure. The intervention itself consisted of comprehensive education of the patient and the family, prescribed diet, social service consultation, planning for discharge, a review of medications, and intensive follow-up. So when we take a look at the results of this study, the number of readmissions for heart failure was reduced by 56% in the treatment group, and this was significant. In a subgroup, quality of life scores were looked at 90 days, and they were improved significantly from the patients in the treatment group. So because of the reduction in hospital admissions, the overall cost for care for these patients was about $450 less in the treatment group. What's interesting to note about this study was that they felt that other interventions were also combined with patient education and information. They said that there was an effort to simplify or consolidate medication regimens. The next category we'll look at is intensive patient care studies. The most common technique was used to educate patients about their medications, resolving medication problems real time, reinforcing physicians' instructions to patients about prescribed medications, reminding patients of the importance of adherence and obtaining refills, and encouraging important patient lifestyle changes. So all 6 of the direct patient contact interventions did lead to enhanced medication adherence, but only one of the telephone or telemonitoring programs led to enhanced adherence. Also interesting, 5 of the 6 direct patient contact interventions were pharmacist-led. The next category we'll look at are complex behavioral approaches. This was a multi-component intervention with an objective to determine the value of self-management counseling plus heart failure education compared with heart failure education alone for a primary endpoint of death or heart failure hospitalization. So about 900 patients with mild to moderate heart failure were randomized between, it was a 3-year period from October 2001 to October 2004. And they were monitored for 2 to 3 subsequent years. Patients randomized to the education group received tip sheets in the mail and telephone calls to check comprehension, whereas the patients randomized to the self-management group received tip sheets in groups and were taught some self-management skills to implement the advice. Self-management education through training and problem solving and collaborating in their own care. The effort was trying to engage these patients more in helping to take care of themselves. What they found, though, at the end of this large study was that there were no significant differences on any secondary endpoints, including death, heart failure hospitalization, all-cause hospitalization, or quality of life. So the last category that we'll look at for heart failure is the simplification of the drug regimen. The CASPR trial was a prospective multi-center study, randomized clinical trial for a period of 5 months. The primary objective of this study was to evaluate and compare compliance with carvedilol or Coreg immediate release, which is done twice daily, versus carvedilol controlled release, which is given once a day. And this study took place in 400 patients. When they looked at the results, there were no statistically significant differences in compliance between the groups, which is surprising. There were no differences in quality of life, treatment satisfaction, or any other physiologic measure. Again, this is a surprising result because what we've learned so far and what we'll continue to learn is that simplification of the drug regimen is key in increasing adherence, and you'll see that as we look at interventions in other types of patients. So to summarize the literature in heart failure, 8 of the 16 randomized controlled trials identified evidence that adherence to medication can be enhanced with the right technique in patients with heart failure. Intensified patient care, particularly involving pharmacists, seemed to be very effective. At least 5 studies did show that it was effective. Evidence, though, that patient education or self-management by itself is not effective in enhancing adherence to medication. These techniques need to be combined with others. So the next disease state that we'll take a look at is diabetes and the literature in the diabetes patient. Piet et al. Did a randomized control study in veterans with diabetes for a year intervention, and this intervention consisted of telemonitoring with interactive voice response and then was followed with a weekly phone call from a nurse to discuss the feedback. So for the patient, during each 5 to 8 minute automated telephone management phone call, the patient used their touch-tone keypad to report information about their blood glucose readings, self-care activities, perceived glycemic control, any symptoms they may be having, and medical care. The nurse educator then followed up with the patients based on their assessment reports. So what do we see as the results? The results of this study, so among patients with hemoglobin A1Cs where their baseline was greater than or equal to 8%, they saw a mean decrease. They saw an 8.7% versus 9.2%, which as you can see is significant. Among the intervention and control patients with baseline values greater than 9%, the endpoint values after the intervention were 9.1 and 10.2% respectively. So this was significant. Several other studies were looking at interventions in the diabetes patient also. One of them looked at physicians using diabetes-specific goal-setting information and feedback about their patients with continuing education. So patients assigned to the physician in the intervention group had statistically significantly lower hemoglobin A1C levels, lower blood pressure, lower fasting plasma glucose levels, lower cholesterol at the end of a 6-year trial when compared with patients who received conventional therapy. These physicians also tended to set up more follow-up consultations, referred fewer patients to diabetes specialty clinics. Another type of intervention may target policies or procedures and maybe even entire programs to help enhance outcomes for patients. One example of this was a study that was done in the UK in an outpatient diabetes clinic. Their objective was to reduce the rate of no-shows at their clinic. The intervention included 1 or 2 components. All of the patients were sent an information packet 2 weeks prior to the visit. This packet told them exactly when and where to come, what to bring, where to park, who they would see, and what to expect. In the group receiving 2 interventions, the first intervention was followed 1 week later by a supplementary telephone call. So the baseline historic no-show rates for this particular clinic prior to the intervention were about 15%. Rates dropped in those receiving only the information packet, so the first group, to 7.3%, which is significant, and to only 1.4% in those who also received the follow-up reminder phone call. So again, as has been the trend of what we've seen, a little bit more of a personal touch seems to be effective, whether it's by phone or most preferably in person. Hypertension. When we looked at the randomized controlled trials that looked at interventions in the hypertensive patient, there were 38 studies testing 58 different interventions and containing data on over 15,000 patients. Duration of follow-up ranged from 2 to 60 months. Here's where we see the simplification of a dosing regimen increasing adherence in 7 of the 9 studies, and they saw a relative increase, while modest, between 8 to almost 20%. Complex interventions comparing more than one technique increased adherence in 8 of 18 studies, ranging from 5% increased adherence to a maximum of 41%. And again, we see patient education alone was largely unsuccessful. So a quick recap on some of the interventions that were studied. Certainly combinations of more than one technique is much more important and much more effective than any one targeted approach. Patient-provider relationships are of vital importance. This communication and understanding does need to be a two-way street. So patient education as a sole intervention, as we've stated a few times, has not been successful in improving medication adherence rates. We're going to switch gears again and review some of the existing technologies and some newer products that are under development. Technologies to facilitate adherence have greatly increased over recent years. The new technologies have capabilities to remind patients to take medications at prescribed times, to monitor adherence from remote locations. Some of the examples include customizable messaging systems that contact patients by phone, email, or text message, electronic pill bottles, mobile phone applications, and in-home monitoring. Some of these technologies also have the capability to transmit data back to the provider's office and/or pharmacy, as well as to place prescription refill requests. Some technology vendors are also linking products to call centers that have 24/7 service that provide patients with immediate access to healthcare providers. So let's just take a look at a few types of these kinds of technologies. So what you see on the screen in front of you are different types of applications for iPhones and iPads. This one is called the Pill Book. It helps set up any type of recurring pill reminders using a flexible scheduling option. It's set up script reminders to let you know when you need to get your prescriptions refilled too. This next application is called Care for Today, and what's nice about this is it also shows a picture of the medication to orient the patient as to what they should be taking at the time that it's due. So just in general, these type of applications for iPhones or iPads are very reasonably priced for most consumers, ranging from 99 cents to under $5. This next technology is interesting. It's called Centacare Pill Station, and it applies concepts of working memory, personalized messaging, and intermittent positive reinforcement to teach and reinforce behavior that hopefully will support good medication adherence. So the Pill Station combines familiar day and week medication organization bins that we've all seen with their patented visualization technology. So it has the ability to take clear images of the medications that are being loaded, and then it takes up-to-date images of the prescriptions after each use. These images, along with some other information, are sent to the Centacare Advisor Center, and advisor monitor images from Pill Station and medications to confirm that the medications match the client prescriptions. So the initial fee for this product is probably reasonable for a lot of patients, but please do keep in mind that there's a monthly fee for the 24/7 support service. This also integrates at the time that a medication is due, the correct bin will light up. It has another feature also called Care Glow. So Care Glow will glow blue if a patient is adherent to most of their medications. Maybe it'll glow yellow if the patient has missed a few medications. And again, this system also has a 24/7 access to an advisor at Centacare where any questions or assistance can be asked at that point. The next device is called Simpill, and it's a web-based program that monitors and detects non-adherence in real time. What's interesting about this is it'll send reminders to the patient if a medication is missed, but then also it can send an escalated reminder to approved caregivers. So if a patient forgets to take their medication, it can be sent to their daughter, their son, their mom, their dad to have them give a call and have their person remember to take their medication. Some other technologies that we see, the vibrating watch, and this would be used to alert a patient when a medication should be taken. There's the automatic pill dispenser with a timer, and this could be used for tablets and capsules. It's very easy to use. And then there's something called a MEMS. A MEMS is a medication event monitoring system, and this records the date and time of each opening and closing of the container. So a visual display shows the number of doses taken during the 24-hour period and the time passed since the last dose. The only issue I see with the MEMS technology is that it can only track one medication. So we may see some value possibly for a high-risk medication, maybe something such as warfarin. This next technology to me is very intriguing. It's called Health Honors, and it actually is customized patient incentives. So this technology creates a patient-centric environment, and it can be used by healthcare payers, manufacturers, and service providers to increase patient adherence. The software analyzes patterns of how people engage, and then the software creates a personal reinforcement plan for every individual, and it helps to maximize the patient engagement. So whenever a patient takes a medication, that they should be taking at the time, they're encouraged to log on to a website and confirm that they've taken their med as scheduled. Then they get a quick phone call back and they get a message and a notification as to whether or not they've received points. These points are redeemable for disease-specific health rewards. So for instance, in an asthmatic patient, they might be able to redeem their points for a peak flow meter, an inhaler, or maybe a book on asthma. What's very interesting is that these points are also redeemable to reduce existing copay benefits. So in other words, your copay benefit level will be dependent on your level of engagement with the program and your level of adherence. So what Health Honors has shown is they've seen increases of anywhere between 33 to 56% in sustained adherence to targeted behaviors. Health Honors just completed their first controlled study. It was 200 diabetes patients, and they were followed over a 9 to 12 month period. What they found is an A1C reduction of a full point with those who used the program compared to an A1C increase in those who did not. So is technology part of the solution? Well, with readmission penalties looming and this gradual shift toward value-based model of care, I think we do need to think outside the box and engage in programs and technologies that can possibly help modify patient behavior. I certainly do view technology as part of the solution to help improve medication adherence, but again, and this is a common theme, it does need to be combined with patient-provider conversations, efforts to improve motivation and understanding of the illness and medications used to treat that disease, and then other patient engagement techniques, as well as drug regimen simplification. When we examine medication use, we really see opposite ends of the spectrum. We see overuse of medications that should not be used, and then we see non-adherence or underuse of drug regimens that are proven to be effective to treat and control chronic illness, both with not such great consequences. Adherence to prescribed medication regimens is critical to patient outcomes, and as we've seen, though, consistent adherence is hard to achieve. I included this next quote because I think it makes an important point. I think we as providers expect a lot from our patients. There was a study that said even medical professionals don't have a perfect record when it comes to medication taking. The survey saw that adherence was 77% for short-term medications and 84% for long-term medications among doctors and nurses. So doesn't it seem unreasonable then to expect that patients can achieve better adherence than the providers without provider intervention? So let's look at some strategies to improve medication adherence in the real world. Certainly, we need to do better at compiling accurate medication histories and the utilization of e-prescribing systems. Enhanced ability to look at post-discharge follow-up and provide post-discharge follow-up on medications can certainly increase utilization, and we can even do this through non-physician clinicians. There's been a lot of advancements in techniques of patient engagement and counseling, and what we do know is that adherence is definitely better when the patient accepts the severity of their illness, trusts the therapist, and believes in the effectiveness of the recommended therapeutic measures. We at Ocean Medical Center did a pilot study several months ago. It was a 10-week pilot study on our 5 West Artella unit, and it was a unit-based pharmacist model of care study. Our objectives were to use the hospital pharmacist to help educate patients on their medications, to help prevent readmissions due to noncompliance, while also increasing HCAP scores. We also, our secondary focus was to complete timely med recs upon admission and then again upon discharge, and promptly resolve medication-related issues to prevent medication errors, increase patient safety, and streamline care. So what the results look like, we were very pleased. The HCAP scores increased for all of the pain, medication, and discharge-related domains, and they increased between 7 to 16%. We found over 150 variances related to medication reconciliation. They were noted and resolved within 24 hours of the patient's admission during our 10-week pilot. So if you extrapolate that to a year period on just one unit at our hospital, we would see close to 800 medication reconciliation related issues that could be addressed and resolved real time. And the real winner here was the decrease in patients with heart failure 30-day readmissions for any DRG. Our baseline was about 20.31%, and we dropped to 17.19% during our pilot. I really believe this is a great example of expanding the role of a healthcare professional, such as a pharmacist, to fill this necessary gap and to help provide a smooth transition of care, both as the patient is admitted and then again through discharge. This model also shows the value of face-to-face patient education combined with other techniques. We tried to simplify drug regimens, and we did intensive medication reconciliation and help the patient understand their condition and the medications being prescribed. Reducing the number of doses per day, utilizing certain technologies, having patients attend peer support groups are great strategies to address medication adherence, especially when combined with other interventions. So as a physician, a nurse, case manager, a pharmacist, it's important to know what support groups are available for the patient populations that you treat. Some more strategies. Up front, we need to identify poor patient adherence. This is key. We've heard it before. We can't fix it if we don't know it's broken. We need to be looking for markers of non-adherence, maybe missed appointments or no-shows, maybe a lack of anticipated response to a medication. Talk to the patient. Ask the patient about barriers to adherence. Talk to the patient about their ability to follow the regimen, and maybe look at a regimen that's a little bit more simple for them to follow. For certain patients, I think it's appropriate to encourage the use of a medication reminder system. Some of the technologies that we looked at could be appropriate. Consider possibly more forgiving medications sometimes if you know a patient is not going to be adherent. Possibly medications with longer half-life. We talk about controlled release or sustained release medications, maybe a depot medication or a transdermal medication. So finally, I'd like to leave you with one last quote. Effective ways to help people follow medication regimens could have far larger effects on health than any other treatment. This was written by Haynes et al. In 2005. So what do we see as we move forward through the next years? Several of the major objectives of healthcare reform are directly related to adherence promotion, including the payment reform, especially a transition to outcomes-based payments. So in whatever shape it takes, let's hope healthcare reform does indeed promote and reward adherence to medications. For as we have seen, poor medication adherence is increasingly a significant source of waste in our healthcare system. So remember what we said earlier, a small increase in drug cost, which is associated with improved adherence, can produce a much larger reduction in overall medical costs. Thank you so much for your time and attention this afternoon. I hope you've enjoyed our presentation.
Thank you very much, Lisa, for that wonderful presentation. It was a great job. Clearly, patient education is necessary but not sufficient to be able to meet the challenge of medication adherence. It will take much creativity on the part of all of our grassroots clinicians in order to determine some of the more effective ways. I can see much research ahead as well in trying to find out what different avenues of patient education or different combinations of interventions will be the most effective. Continuing education credits, as I said before, are available, but we do need you to complete the appropriate session evaluation. If you are not in a group session, please do go back to the website and take that evaluation down from the site, fax it to 732-776-4837, and ensure that you add your contact information so that we may appropriately return your certificate. Thank you again for joining us today. We're very pleased to have you join us for our webinars. Our next one will be on motivational interviewing, a wonderful technique that is devised to increase people's involvement and engagement in their own care to improve their health behaviors. This program will be offered on July 24th again at noon. Thank you very much for joining us and have a good day.